All right, good evening, everyone. Welcome to this weekend tutorial. And we'll be looking at something very interesting, both in the ICU and in our surgical and trauma patients. So we'll be looking at pulmonary embolism this evening. All right, we'll follow this outline. And then our learning outcomes at the end. I trust that all of us will be able to understand the pathophysiology and mechanisms of pulmonary embolism and its impacts on CVS and respiratory system. At the end, we should be able to recognize the risk factors and symptoms of pulmonary embolism, especially among our patients in the ICU. I hope that at the end, you'll be able to apply diagnostic tools and are able to interpret important clinical scoring systems and imaging modality for timely and accurate diagnosis and management of pulmonary embolism. All right, should be able to develop an evidence-based management strategy, which includes anticoagulation, thrombolysis, and other interventional therapies. All right, we should be able to adapt diagnostic and therapeutic approaches for patients with PE, and we should be able to identify factors that affect the outcome of PE and utilize scoring systems like the PE exclusion system criteria. All right, and at the end, we should also be able to align approaches to reduce the risk of venous thromboembolism in our high-risk patients. All right, so the first thing we're going to do, like we used to do, look at this clinical scenario, and I'm going to read it, after which we have 5 questions that we will answer. I have 2 clinical scenarios here. So Clemence Tuyisime is a 45-year-old female patient who's been admitted to the ICU. Please follow carefully so that you can answer carefully also. All right, she's a 45-year-old female patient admitted to the ICU who has undergone laparoscopic cholecystectomy 5 days earlier. All right, she has had progressive dyspnea over the past 2 days in the course of her ICU admission, and on evaluation, she appears tachypnic and mildly cyanotic. Her vital signs range: heart rate 120 beats per minute, blood pressure 90/60, respiratory 28 cycles per minute, SpO2 is 88% room air, and she has no fever, temperature 37. So physical examination reveals no signs of infection at the surgical site. The JVP is elevated, but the pressures are clear, and there are no lower limb swelling or erythema. Our investigation results include sinus tachycardia on ECG. All right, she has pH of 7.44, PaCO2 of 32, PaO2 of 60, and bicarbonate of 22. However, her D-dimer is elevated at 1,200 nanogram per mil. Chest X-ray has clear lung fits. All right, do we appreciate the clinical scenario? Can we go to the question now? Are we ready?
We're ready, sir.
Yes, sir.
All right.
Yes, sir.
So question number 1, what is the most likely diagnosis for this patient?
So I think it's pulmonary embolism, sir. Venous pulmonary embolism.
Pulmonary embolism, okay?
Yes, sir.
What are the key clinical features that support your diagnosis?
The chest is clear, sir. But again, the BP, the blood pressure is low somehow. It tends to support. Then the low POC, the hypoxia that is there, the tachypnea, and the low POC, there's flushing off of carbon dioxide, the respiratory distress, as it were.
Okay.
And I think there's chest pain there too.
All right, great. Belema Oduma, you raised your hand. You want to say something?
Yes, sir. From the scenario, first of all, for the type of surgery, she has a laparoscopic system, polycystem. It can also, since it's laparoscopic, she can have from um she can have pulmonary embolism from that. That's number one that will support it. Then with other things that the previous person has said, then the D dimer also is elevated.
Okay, great. Two people are raising their hands quickly. Are you, George Undusi? Quickly.
Good evening, sir, from here, sir.
Good evening, yes.
Yes, sir. So, in addition, sir, the the BP, the pulse, and then the raised JVP. The raised JVP is also a sign that there's an obstruction in the upper vessels from the superior vena cava down to the pulmonary arteries. So that's also a sign. That's also another thing that will also tie me up to the diagnosis of pulmonary embolism.
Yes. And Gloria wrote in the chat, elevated D-dimer. Okay. Gloria, what do you think? Elevated D-dimer, does it always point to pulmonary embolism?
No, Prof, it doesn't always point to pulmonary embolism alone. You need other criteria to make the diagnosis, but an elevated D-dimer gives you an idea that
Beautiful.
there might be pulmonary embolism.
All right, Fabian, Onovigose. Am I correct? Onovigose. Something like that.
Yes,
Fabian,
sir.
go ahead.
Yes, sir. Yes, sir.
What's
Yes,
that
sir.
name?
I will not really
Onovigose. What's that?
go for pulmonary. Onowigose.
Yes.
Onowigose.
First way get money, now they do it in.
They dress well. To dress.
All right, Fabian, go ahead. Go ahead with your answer.
Okay. I said I will not really go for pulmonary. I felt that if it were pulmonary embolism, the ETCO2, it doesn't support the diagnosis. It will be low, then also the tachycardia will more bradycardia. And usually these patients are presented for 2 days with this dyspnea. So I felt that it would.
So what do you think it is if it's not PE?
Would have been, it's more of an emergency. So those are my thoughts. Possibly there would be, my differential would be complication of either long atelectasis.
Okay,
So
guys,
any other
what
thing
will
I would
be
have
what
thought
is
in
your
case
next
would be
best
mismatch.
diagnostic step? Let's rush quickly.
BCT
Okay.
pulmonary angiogram.
Okay.
Okay. What other alternative diagnostic tests can you employ?
You can do a bilateral lower limb Doppler. Do a chest X-ray.
Okay. What other things can you do?
So we can also do an ECG.
Do it.
ECG.
Yes, ECG, D-dimer test.
Echocardiography.
All right, Olayinka Fashion said bedside echocardiography. What will you see on bedside echocardiography? Zeno Gloria, I agree with you, CTPA. Computer tomography, pulmonary angiography. Good. What will you see on bedside echo? Olayinka Fashion.
On bedside echo, you may see signs of left ventricular strain.
Sorry, I didn't hear you.
You may see features of left ventricular, right ventricular strain, rather.
Right or left?
Right ventricular strain.
Right ventricular strain. How will you see that on your bedside echo? That's what I'm saying. How will it show right ventricular strain? Because right ventricular strain, you can see it on ECG with your elevated S wave on the lead one. So what is special about bedside echo that will show you, right ventricular strain? Dilated, yes, dilated right ventricle. I've seen someone. MHSS, please, we've told you to write your name, please, so that we can identify who is talking. Dilated right ventricular, right ventricles, good. High pulmonary artery, pulmonary pressure, correct. Paradoxical septal motion. What is that, Pascal? What is that sign called? Paradoxical septal motion. What is that sign called, Pascal? This sign will show you right ventricular strain, correct? This sign, that is for right ventricular strain. Paradoxical septal motion is what? Your Myconius signs, isn't it? Let's go ahead. Westermann sign on chest X-ray, yes. All right, we'll talk more about that. George, what is the difference between Westermann sign and Pallas sign on chest X-ray?
I didn't get you, sir.
What's the difference between Westermann sign and Pallas signs on chest X-ray?
So I can't exactly recall, but I know that Westermann sign is an area of oligemia preceding the where you have the clots. So there's an area of oligemia on the chest X-ray within that area, sir. I know that's Westermann sign. I don't know that of the Pallas sign, sir.
Okay, all right, good idea. The peripheral oliguria is because of the obstruction, all right? And you will see that obstruction on your Pallas sign. We'll talk more about that. Good ideas, guys. I'm impressed. That means you read this. So what is the immediate management priority for this patient? Quickly. Quickly.
Anticoagulation, sir.
Sorry?
Anticoagulation, sir.
Anticoagulation, would that be your immediate management priority?
So I want to.
It's oxygenation.
Oxygen, are you immediate correct? You give this patient oxygen, correct? After oxygen, what is next? Then you can anticoagulate. All
Yes,
right.
sir.
Beautiful. So let's go. We have a lot to talk about. But I'm impressed. All right. This second one is Esperance Pulmonary. A 32-year-old woman who presents to the ICU 3 days postpartum after an emergency cesarean section. She reports sudden onset chest pain, severe dyspnea, and a feeling of impending doom. A further sign, she's tachycardic with 140. She's hypotensive 80/50, tachypnea, respiratory of 32, SpO2 of 85% of 6-liter oxygen via nasal cannula. And she's afebrile, temperature, low fever. On physical examination, there's cyanosis of the lips and extremities. GVP is elevated. There are some crackles along bases, then tenderness and swelling of the left calf. Investigation, ECG sinus tachycardia, pH of 7.8, pH of 30, PaO2 of 55, D-dimer 2,500 nanogram per mil. And lower limb ultrasound shows left femoral vein thrombosis. So this is straightforward, isn't it? What is the most likely diagnosis? PE, isn't it? Do we agree this is most likely a pulmonary embolism?
Yes, sir. Secondary
So
to
what postpartum physiological changes increase the risk of PE in this patient?
hypercoagulation, sir.
Hypercoagulable state, correct. Number 2, she's postpartum. What again in terms of physical activity?
Immobility.
Reduced mobility, immobility,
Immobility,
correct.
yes.
What again in terms of hormonal changes? All right, there's increased Hormones, estrogen and progesterone, these are also stuff that can lead to hypercoagulable state. So what are the ECG findings? Commonly associated, we've talked about some of this. So what is the role of D-dimer in this case? Gloria, you remember you mentioned D-dimer. What is the role of D-dimer in this case?
D-dimer will be elevated.
I said, what is the role? Gloria, you mentioned D-dimer earlier on.
So in this case, the role of D-dimer in this case, D-dimer will not be diagnostic because not ordinarily in pregnant women, D-dimer is markedly elevated. So it won't really give a guide in this case. Sir.
Beautiful, beautiful. So D-dimer will not point to it, and that's why we gave that value, okay? Given that the patient is hemodynamically unstable, what diagnostic imaging is preferred for this patient? The blood pressure is 80/50.
Bedside echocardiography, sir.
Sorry?
Bedside echocardiography.
Bedside echocardiography, yes, because the patient is unstable, you can't take this patient to CT for pulmonary angiography. So what immediate management steps you should be taking? This is how exam goes, all right? This is how your exam will go, especially for your OSCE.
Sir, immediate steps would be ventilation, intubation, and ventilatory supports.
Okay.
Is it ventilation or oxygenation?
With ventilation, you can give oxygenation. FiO2, starting with FiO2 of 1, the target of 0.4. Then you also need anticoagulation also.
Okay, great, great. So let's go ahead. Well done, guys. I'm impressed, all right? So by way of introduction, pulmonary embolism is often a life-threatening condition, okay? Olayinka has enumerated it here, okay, great. All right, it's a life-threatening condition caused by obstruction of pulmonary arteries or their branches, all right, most commonly caused by thrombus that originates in the deep veins of the lower extremities. P is a critical component of your VTE, which also includes your deep vein thrombosis and pulmonary embolism. All right, it's estimated to occur around 60 to 70 per 100,000 people annually. All right, and the high-risk patients, ICU patients, that's what we're talking about it here. The risk of pulmonary embolism is increased by 10 to 20 times. And this is due to the critical illness or injury, immobilization, and the different intervention therapies that are instituted in our ICU patient. Post-surgical patients, like our patient who had cholecystectomy, trauma patients, and those with cancer. The female gender seems to have likely predominance incidence of PE due to pregnancy state, like we saw in our patient postpartum and patient hormonal therapy. Okay. All right, so let's look at the overview of the pathophysiology. All right, overview. The first thing is that there's a thrombus formation. All right, and when this thrombus forms in the deep vein system of the lower limbs or even in the pelvis, it embolizes into the venous system. All right, travels through the venous system, through to the right heart, and to the pulmonary artery 3. So once it gets there, it leads to obstruction of pulmonary blood flow, and that's when you have increased pulmonary vascular resistance, and this will lead to right ventricular overload and dysfunction, and that's when you see a right ventricular strain. And because of ventriculation perfusion mismatch and impaired gas exchange, you have patients with hypoxemia. All right, so this is the flow chart. DVT forms in the lower limbs or in the pelvis. All right, and this embolizes right into the venous system, goes into the pulmonary artery, causing obstruction. This will lead to ventilation perfusion mismatch, right ventricular strain, hypoxemia, and all this will show in your clinical manifestation of dyspnea, chest pain, and shock. All right, so I've said this before, but let's quickly go through this. So pulmonary emboli are typically multiple. The lower lobes are more involved frequently than the upper lobes. All right, and bilateral lung involvement are more common. Okay. So large emboli tend to obstruct the main pulmonary artery, and this is what you'll see causing pseudoembolus with severe cardiovascular consequences. Small size emboli, on the other hand, block the peripheral arteries, all right, and this can lead to pulmonary infarction, which is manifested as intra-alveolar hemorrhages. All right, in about 10% of patients, pulmonary infarction occurs, all right, and this is due to small size emboli that may not cause hemodynamic dysfunction, but you can lead to pulmonary infarction with severe hypoxemia. All right, we talked about this so that we don't take much of our time. The pulmonary vascular resistance increases, and with increase in pulmonary artery pressure, especially if the emboli or embolus occludes more than 30 to 50% of the total cross-sectional area of the pulmonary artery bed. This increased pulmonary vascular resistance raises the right ventricular afterload, all right, and in an attempt to overcome the obstruction, the right ventricle overworks itself, and you have right ventricular dilatation, and which leads to the flattening or the bowing of the intraventricular septum. And this is what leads to these signs that you see on your parasternal short axis echocardiography. All right, so this decreased right ventricular outflow will obviously lead to reduced left ventricular filling, compromising cardiac output, and that's when you have shock or hemodynamic instability in this patient. All right, etiology, embolization of a div, most of them is due to a thrombus. Then you can have fat or bone embolization, which could be secondary to trauma or during orthopedic procedures. Others are emboli from your central venous catheterization. Tumor cells may embolize from their primary site, and even in our parents, pregnant women, you can have amniotic fluid embolization. So it's not just about thrombus alone, although it accounts for 80 to 90% of cases of pulmonary embolism. But fat, bone, air, tumor cells, amniotic fluid can also embolize into the pulmonary system, which will give you a presentation of pulmonary embolism. So we look at these risk factors, all right, the Vicros triad, you remember that, starts with venous stasis, abdominal blood flow, all right. Then we have ventricular injury, and a lot of times we underreport venous wall injury from our, venipuncture and all that, especially with catheterization of large vessels. Then we have hypercoagulable states like the Pathophysiology mutation, deficiencies of protein C and protein S. All right, types. There are two major types of PE in terms of hemodynamic status. We have those who are cause hemodynamic instability, what we know as the massive or the high-risk pulmonary embolism. All of this will cause hypotension, and patients with hemodynamically unstable PE are more likely to die from obstructive shock. All right, this makes sense from the pathophysiology. There are some patients that have pulmonary embolism, but they're hemodynamically stable. All right, and it ranges from mild symptomatic or asymptomatic PE. This can cause hypotension, but most of the times the hypotension responds to adequate intervention like fluid therapy, and sometimes those who come with right ventricular dysfunction may have some hemodynamic stability. So this one will respond to fluid therapy, and sometimes giving inotropes will help. So clinical features, okay, let's go into this. Risk factors. I like mnemonics by now, you know. So risk factors for PE, especially in the ICU. In ICU patient, just remember chest. Everything about PE is chest. All right. So see, the first is the central venous catheter use. So the reason why this is important is that when you have patients who seem to present with clinical symptoms of PE in the ICU, remember, if they are on all or any of these, the risk increases. So the patient with central venous catheter use, patients who are malignant, septic, or pregnant patients, or patients who have thrombophilia, all right, patients who are on extracorporeal life support, like ECMO, patients who have been in ICU for a long time or who are mechanically ventilated. All right, mechanical ventilation will cause increasing mobility. Patients who have undergone surgery. We talked about patients who are hemodynamically unstable, requiring high doses of your vasopressors or inotrope. Trauma patients, polytrauma patients, especially involving the lower limbs and the pelvis. These are risk factors that are specific for patients in ICU. All right, so generally you have, chest pain, which is pleuritic in nature. You can have cough, hemoptysis, all right, for the general patient. Hypoxia, all right, everything is chest. You see ECG changes of right heart rate. Patient is hemodynamically unstable with shock, tachypnea, and tachycardia. And the two clinical scenarios we saw before, all right, all of these features were seen in them. All right, so there are scoring systems that have been devised to assess the risk of pulmonary embolism. All right, so the first one is the Geneva score. All right, and if you see what I've done here, I've tried to help you to remember Geneva score. So Geneva score is Geneva. So the first point is G, general surgery. Patient have undergone general surgery, you give the patient 2 points. Patient comes down with hemoptysis, 2 points. Patient with neoplasm, that's the aim, 2 points. Edema, which is unilateral, all right, that is the E there, 4 points. Patient with history of venous thromboembolism in the past, we have 4 points. If the patient is elderly, age greater than 5, we have 1 point. So anytime you want to do risk assessment, write Geneva and put these points there. All right, the interpretation, when your score is between 0 to 3, there's a low clinical probability of PE. So what we're doing is if the patient presents with signs and symptoms of PE and you do a Geneva scoring and it's between 0 to 3, the probability is very low, right, with approximately 8% of prevalence of PE. All right, but between 4 to 10, intermediate probability with 28% prevalence. And if your Geneva total score is greater or equal to 11, the probability is very high, with about 74% of risk of developing PE or having PE in the patient. So look at it. It's important not just to look at the clinical probability. It also informs you what to do next. All right, if the patient has a low Geneva score, 0 to 3 with low probability, you want to do your D-dimer testing. And if the D-dimer is normal, you can rule out PE and go to sleep. For patients with intermediate probability score of between 4 to 10, you want to perform your diagnostic. Where am I? Okay. You want to perform your diagnostic imaging, your CTPA. All right. This diagram may be useful if imaging is not immediately available or the patient is hemodynamically unstable. But if the probability score is very high, greater or equal to 11, you want to proceed directly to CTPA and consider empiric anticoagulation. even before you get the result of your PE, all right, of your CTPA, or your patient is too unstable to be able to move to the CT suit. The second risk assessment score is the WES criteria, which has had different modifications, all right? So if the patient has clinical symptoms of DPT, you give the patient a score of 3. Now, if in this case, the diagnosis is less likely than PE, other diagnosis less likely, that is, you have high index of suspicion of PE, 3. If the heart rate, the patient is tachycardic, you give 1.5. If the patient has been immobile for 3 or more days or has undergone surgery in previous 4 weeks, you give the patient 1.5. If the patient has previous history of DPT or PE, all right, the patient will have a score of 1.5. Hemoptysis will give a score of 1, and malignancy a score of 1. How do you interpret that? This the revised or the modified WES scores makes it easier. So if the total score is less or equal to 4, the probability is less than 15%, about 15%. So you want to do the D-dimer test. All right. If it's normal, you rule out P. All right. But if the total WES score, modified WES score is more than 4, P is likely with a probability of about 40%. You want to proceed with your CTPA to confirm your diagnosis. All right. So what are how do you make your diagnosis? The routine test, like we mentioned, elevated plasma D-dimer. Like we said before, D-dimer is more of an exclusion test. That is, a normal D-dimer excludes the presence of thromboembolism. But elevated D-dimer does not always confirm P, because there are other factors that can cause elevated D-dimer. All right, so there's an age-adjusted cutoff D-dimer level, which is age times 10 microgram per liter for patients who are more than 50 years of age. So, example, if your patient is aged 75, the age-adjusted D-dimer will be 750 microgram per liter, rather nanogram. That should be nanogram. All right, so after you've done your elevated plasma D-dimer, the ABG analysis will show hypoxia. If you look at our clinical scenarios, the 2 of them had hypoxic events, PaO2 of 55 and 60. All right. Now, if you have unexplained hypoxemia, despite a normal chest X-ray, your clinical suspicion of PE should be raised. You want to do other coagulation studies like your prothrombin time, your activated partial your APTT, your TT, your troponin time, and all of these are your routine tests. Then you do your electrolyte, urea, creatinine, and sometimes you may even do your complete blood test, your full blood count. There's specific investigations that were mentioned. All right, like I told you, everything about P is chest. So this is chest X-ray, Pala sign. All right. So you were right. Somebody mentioned the Westermann sign, but there are 2 that you'll see on chest X-ray. All right. You will see enlarged, for instance, on this X-ray, the P is on the left lung, all right, increase in blood flow on the right side, but minimal blood flow seen on the left. So there is obstruction in the pulmonary vessel here. So this side looks like clearer, is the side with reduced blood flow, all right? So that's where you see the clots there. The Westermann sign, you see, is the peripheral oliguria that you see. And I remember somebody mentioned Hampton's form, all right? This is a triangular or rounded pleural-based infiltrate, all right, with the apex pointing towards the hilum, all right, of the lung, usually located adjacent to the hilum. So there are 3, for instance, if I ask you an exam, mention the 3 radiological features of PE, I want to hear Palo sign, I want to hear Westermann sign, and the Hampton sign. Okay, so these are the 3 things that you want to remember the Pallas sign, the Hampton sign, and the Westermarck sign. Westermarck sign, all right. Then you do your ECG, all right, you see sinus tachycardia, all the patients, all right, sinus tachycardia is actually in an attempt to compensate for the reduced cardiac output, all right, you can see right about bundle branch block. There's also non-specific ST depression and T-wave inversion, all right. The echocardiography findings, let's go for it, all right. Now, the echocardiography, this is very crucial, especially for patients that you are too hemodynamically unstable to be moved for CTPA. Cardiac ultrasound will actually give you a good, especially if you are using the parasternal short axis, okay, window. You see that this is the right ventricle, all right, is trained in trying to, overcome the obstruction in the major pulmonary artery. And because of that, the interseptum, the intraventricular septum bows out or flattens out. So you see the D shape of the left ventricle, all right? So another thing is that the right ventricle, normally the left ventricle is bigger than the right ventricle, but because of left ventricular dilatation, dysfunction, you see that the right ventricle becomes bigger. So you have your right ventricle, left ventricle ratio greater than 1. And this is what is causing the flattening of the intraventricular septum. Okay, the Marconi sign, all right, this is regional wall motion abnormality, especially in the mid-free wall of the left ventricle, all right? The motion of the right ventricle at the apex is normal, but in the mid zone here, you have hypokinesia, and that is what you know as the Marconi sign. So the clinical, the features on cardiac ultrasound for PE, you have the D sign and you have the Marconi sign. Sometimes you may see a thrombus floating or embolus floating, all right, in the right ventricle, all right. It's very rare, but sometimes you can see that, which gives you an indication of pulmonary embolism. Now, log ultrasound also can be used in the diagnosis. Is an indirect sign, can give you an indirect sign of PE, all right? So you have the pleural wedge-shaped lesion, all right, which shows peripheral infarction. Remember that I told you that the smaller sized emboli will not cause more hypotension or will cause pulmonary infarction. And this is what you see, all right, on lung ultrasound. Absence B lines or pneumothorax in a patient with acute respiratory distress will point to pulmonary embolism. So when you do not have a B line and there's no pneumothorax, but this patient is still hypoxic or is in acute respiratory distress, lung ultrasound helps you to point to pulmonary embolism. Now, somebody mentioned the Doppler, all right, we call it the compression ultrasound of the lower limbs, all right. The key features here, what you're trying to do is that you want to delineate the presence of DVT, all right, where the embolus most likely originated from. So it's a clinical sign. I hope we know how to do that. It's very simple. It's something you can do within 5 minutes. And you look for the femoral and the popliteal vessels, and you're able to identify them. You can use your collar Doppler. It will help you. And if there's lack of venous compressibility because of the presence of a thrombus, the veins will not be compressible, and it gives you a hallmark that there's a presence, a hallmark sign of DVT. Sometimes you can see the thrombus in the popliteal, especially in the popliteal and the femoral vein, all right? Sometimes you do venous flow abnormalities, but some authors, some clinicians, I don't like doing this because in trying to augment flow, you can dislodge that thrombus and it embolizes. But some people do it in augmentation, all right? And there's no flow despite you're trying to augment flow, which suggests the obstruction. All right, so it's important, especially in the emergency room and out of ICU, to do what we know as the pulmonary embolism rule-out criteria. All right, now this shows that the idea of this is that if all of this is present, there's no need of pursuing a diagnosis of pulmonary embolism. So if a patient fulfills this 8 criteria, the patient is younger than 50, is not tachycardic, SpO2 is greater than 5%, there's no hemoptysis, no use of estrogen, no prior DVT or PE, no unilateral leg swelling, no surgery or trauma that require hospitalization within the preceding 4 weeks. You can definitely say that there's no PE in this patient. So that's what we know as the pulmonary embolism rule-out criteria. All right. So patients having a low probability of PE who fulfill all the 8 criteria we mentioned, we can safely say that the likelihood of pulmonary embolism is low. Therefore, no further testing is indicated. All right. But don't forget that this is only valid in clinical setting where prevalence of PE is less than 15%. All right. So it is not something that we use commonly, especially in settings where we have high-risk patients like the ICU. All right. So in hospital settings with a higher prevalence, more than 50% PE, like in the ICU, the pulmonary embolism rule-out criteria, all right, has weak as predictive value. So it should not be used for patients with intermediate or high suspicion for PE, or for patients who are in the hospital hospitalized with suspected features of PE. I hope that is clear. So we only use pulmonary embolism rule-out criteria in cases where the prevalence or the incidence of PE is low. So diagnostic criteria, all right, for a patient with low probability, West score less than 2, all right? So if the pulmonary embolism criteria are fulfilled, there's no further test, no need for test, and you can exclude PE. But if the PE ROC criteria are not met, you should obtain a day dimer. If the dimer is negative, all right, less than 500 nanogram per mil, PE can be ruled out. But if it is more than 500 nanogram per mil in a patient who is less than 50 or higher after age-adjusted D-dimer value, you should obtain a CTPA, all right? If a CTPA is inconclusive or contraindicated, you want to obtain your VQ scan, all right? But this is for patients with low probability of PE. For patients with intermediate probability, West score between 2 to 6, you want to measure your D-dimer. If it's negative, rule out PE, all right? If positive, proceed to do CTPA. These are algorithms that should be followed. But if your CTPA is inconclusive or contraindicated, you want to obtain your VQ scan. Now, for patients with high probability, West score greater than 6, you want to go ahead and perform your CTPA immediately as an emergency. If you are not convinced, you want to do a VQ scan. If the VQ scan results are intermediate probability, further testing with low extremity compression ultrasonography with Doppler will be appropriate. Now, if you can just do that and you're able to decide that there's a presence of DVT with your compression ultrasonography, go ahead and manage this patient as a case of PE. Okay, so I mentioned some of this before. Bedside echocardiography, venous compression ultrasonography are useful, and it's very important, especially in in potentially life-threatening PE in high-risk patients. All right, so quickly, I have 4 minutes more. Management of PE, all right, you want to, this is dependent on the grading, severity grading, all right? You have mild PE, moderate, all right, or massive PE. All right, in my PE, there's PE, but the patient is hemodynamically stable. It does not have any right ventricular dysfunction. All right, and moderate PE, the patient is stable, all right, with evidence, all right, ventricular dysfunction, your D sign or your Myconius sign is present. For patients with massive PE, these are patients who are hemodynamically unstable and there's evidence of hypotension. The two patients we saw in a clinical scenario had massive PE, all right, with hemodynamic compromise. George, allow me to finish. You will talk. I can see you raise your hand. I'll soon finish. Or is it urgent? You want to say something urgently? George? Okay, I think we can continue. Okay, the algorithm, all right? So low risk PE, start anticoagulation, all right? And consider early discharge. You don't want to keep that patient in the ICU, continue to immobilize. You want the patient to mobilize. Submassive or your moderate PE, you want to start your anticoagulation and assess for thrombolysis, especially in the presence of right ventricular dysfunction. All right, massive or excuse me, massive E with a shock, hemodynamic instability, immediate thrombolysis is indicated, all right, or surgical embolectomy. And this patient will require both hemodynamic and respiratory support. All right, so chest, you look at the treatment, okay? For this patient, somebody was talking about that, especially in the second scenario, that postpartum patient, you want to ventilate the patient. So control mechanical ventilation is indicated, especially when the SpO2 is less than 90%. All right, so oxygen and mechanical ventilation is the first thing you want to do. The anticoagulation with heparin, all right, low molecular weight heparin, all right, is indicated initially, and why you can, change to warfarin therapy, all right, later on, but you want to give your therapeutic dose of low molecular weight heparin at first, all right, which is at 1 milligram per kg. ECMO may be used in hemodynamically unstable patients with pulmonary embolism until the embolism clears. All right, this is also very crucial. But where you do not have echo, hemodynamic and respiratory support will suffice here. Surgical embolectomy is indicated in patients with hemodynamically unstable PE, in whom thrombolysis is contraindicated for patients who have failed thrombolysis. All right, thrombolysis for severe or massive PE when surgery is not immediately available. All right, and you want to use your tissue plasminogen activator at 100 milligram IV. All right, so we have what they call indices of poor prognosis. Most of the patients with severe or massive PE die in ICU, and the indices for such poor prognosis include shock. Patient comes in hemodynamically unstable. Patient have right ventricular dysfunction. And for patients who have had DVT in the past, now having an pulmonary embolism, the prognosis is usually very poor. So we have what we call the pulmonary embolism severity index. All right, it's something that I want you to look at. Where we have there are two types of them: the pulmonary embolism severity index, and we have the modified one. So just look at the age, 1 point. If the patient is more than 80 years, you give 1 point. The male gender, 10 points. Cancer, 10 points. All right. For the test criteria, when they say heart failure, chronic heart failure, 10 points. Patient chronic pulmonary disease, 10 points. Another, let's see. So risk stratification. So for class 1, all right, to look at the severity of the PE, if the point is less than 65 for your pulmonary embolism severity index, all right, where it has a low 30-day risk of mortality. But for class 2, the PES score is between 66 and 85. It also has low mortality risk of between 1.7 to 3.5. But when you have from class 4 to class 5, your PES point 106 to 125 has high mortality rates. All right, almost 10% of such patients die. But if the points is more than 125, about a quarter of those patients will die. And this is important, especially in counseling relatives in the ICU to calculate the pulmonary embolism severity index. So complications of PE is also chest. You can have chronic thromboembolic pulmonary hypertension, because we remember we talked about the increase in pulmonary artery pressure, so it can become chronic. That is the first C there. You can have heart failure resulting from it, all right? That is the H. Then shock. Patient can have cardiogenic shock, and once a patient has developed DVT, the likelihood, especially for patients who have hypercoagulable states, they can have recurrent thromboembolism. So these are some of the complications. All right, beautiful, we made it. So these are the references, and let me stop recording so that we can have comments and discussion.